Okay. I think we stopped at. Okay. I think we stopped that question. This particular question. So we are going to question 9 now. Okay. So I'll be reading. Just answer them. 72-year-old man comes to the physician because of 1 month history of discoloration of his legs. He lives alone and his diet consists mostly of oatmeal and prepared meat. Physical examination shows ecchymosis of the lower extremities, splinter hemorrhages of the nail beds, perifollicular purpura, and corkscrew hairs. The deficiency of which of the following vitamins is most likely responsible for these findings? So, guys, what do we think?
Vitamin C.
Yeah, so this one is very straightforward. Once we see features of skin hemorrhages like the perifollicular hemorrhages or the purpura, the corkscrew hairs. Sometimes we might talk about gingival bleeding. We know that that should be vitamin C. So look, you know, we should pay attention to that. Okay. Patients with hyperuricemia are most likely to have deficiency of which of the following enzymes? Hyperuricemia. So we have to look through the enzyme and choose the one that will have hyperuricemia. Which one? Which one do we think? Adenosine deaminase, adenosine phosphoribosyltransferase, adenylate deaminase, hypoxanthine guanine phosphoribosyltransferase, or xanthine oxidase.
C.
Okay, so deficiency of D is causing what?
Yeah.
The what?
Ishnian syndrome.
Yes, Leishman.
Maryland.
Yes. So that is the enzyme that is important in the salvage pathway for purine. So you need that enzyme to help you scavenge all the um guanine and the hypoxanthine that we have degraded. If you guys remember the way the nucleic acid works, so nucleic acid are composed of nucleotides. So they are composed of so many GMPs, AMPs, IMPs, and all those things. So you can not IMP now. Let me just say AMP, JMP, CMP, and TMP. So we can break them down. So once we have degradation of DNA, maybe you are recycling, then you want to synthesize another one, you break down the old ones. So in the process of breaking them down, they can get convert. Let's take GMP for an example now. So you can break down your GMP to guanosine. So if you remove one phosphate from GMP, you convert it to guanosine. Guanosine is just the dephosphorylated form of GMP. So that's a nucleoside. Guanosine is a nucleoside. So GMP is a nucleotide because it contains that phosphate. It's made up of three things: the sugar, the base, which is guanine, and the phosphate. Those three makes it a nucleotide. But once you remove the phosphate, it has only the sugar and the base. It's a nucleoside. So you can also decide to remove that sugar and it will remain only the base. So when it remains only the base, it's guanine. Now all those guanine can just be lying freely in plasma. Why not just recycle them? Just convert them back to your GMP so that you can save yourself the long pathway of starting from ribulose 5-phosphate. Starting from ribulose 5-phosphate, moving downwards towards is very long. So just scavenge all those guys, salvage them, and reconvert them into the nucleotide. How can you do that? So you guys remember that we said guanine is what is living in plasma. That is what is free in plasma. So that means you have to add a ribose sugar and a phosphate group, right, to make it GMP. I hope you guys agree with me. Hello?
Yeah.
So So the source of that ribose sugar and the phosphate is PRPP. That's phosphoribosyl. That is the ribose part. Phosphoribosyl. Pyrophosphate. That's the phosphate part. So once you join phosphoribosyl pyrophosphate to your guanine, you get your GMP. You can also join phosphoribosyl pyrophosphate to hypoxanthine to get IMP. So that means you have to use that a particular enzyme can catalyze both out of guanine and hypoxanthine. That's why I call it hypoxanthine guanine phosphoribosyl transferase. That is something that can help you transfer the phosphoribosyl group to guanine or hypoxanthine to form GMP and IMP. That's a very short pathway. Now, an individual that lacks that enzyme cannot do that. So that means that what is the mechanism by which they will synthesize their purine nucleotide? How would they go about it? That means they have to start from the starting. So if you guys remember that pathway, maybe I have to open my book now so that I will not just be saying everything now to be abstract. So um, that means those guys need to start from the starting, then very long pathway, very long pathway. So I'm coming. So that's why an enzyme that we call phosphoribosyl amidinotransferase. Do you guys remember that guy? Anybody remembers phosphoribosyl amidinotransferase? Anybody? Or we have forgotten about it? That is the enzyme,
And which pathway?
the purine pathway. You see,
Okay.
in individuals with the Leishmanian, you have to remember that enzyme. It's very important because that is what is now going to drive that pathway and will now lead to the pathophysiology of Leishmanian. So let's see. I'm coming. I'm coming. Let me get there. Sometimes they ask that particular enzyme. We have to remember it. We have to remember. It's very important. Um, I don't want to waste too much time. So
Mm.
if you guys also have your first aid with you, you can open it to the place so that you can. Yeah. So this is the purine salvage pathway. So you have our basis here, the basis which is a guanine here, being converted to GMP by the activity of the enzyme PRPP, the HGPRT, that's the enzyme, combining PRPP with the guanine to form GMP. It's also doing it on the other side, adding PRPP to hypoxanthine to form IMP. It's salvaging those free bases. It's salvaging those free bases. Now, if somebody lacks that enzyme, that means you cannot synthesize guanine, you cannot synthesize GMP and IMP through that pathway again. That means you have to start from up. You guys can see ribose 5-phosphate is a starting, that's a de novo synthesis. De novo synthesis means the actual synthetic pathway. So it's going to start from that ribose 5-phosphate to IMP. But you guys can see that it's moving from ribose 5 to IMP, but it's not that straightforward. It is not one reaction. It is not one reaction that is moving it from ribose 5 to IMP. It is a very long reaction, but we don't need to know. We don't need to know everything. We are not expected to know them. What we just have to know there is that one of those reactions involve synthesis of PRPP. That is why you need to take ribose 5-phosphate to PRPP. So that's why PRPP synthesis is involved. Then you also need to convert PRPP to another metabolite like PRPA, which is phosphoribosylamine. That enzyme that does that is PRPP amidinotransferase. That is the committed step in purine synthesis. If they ask us what is the committed step in purine synthesis, That is the enzyme that catalyzes it. PRPP amidotransferase. You guys remember, say there's a compensatory increase in purine synthesis through increased PRPP amidotransferase activity. Very important. So that is now what is now going to drive that pathway downwards. You begin to synthesize IMP, inosine, hypoxanthine, xanthine, that will now go to form uric acid. That is why you have hyperuricemia in somebody with Leishman syndrome. I hope you guys understand what I'm trying to explain.
Yeah, but I have a question. And my question is the PRPP amidotransferase, what does it produce? Like, what's the
Okay,
product
like
of the.
if you want to know it, it's fine, but it's not really very important. It produces uh phosphoribosylate amine, not phosphoribosylate pyrophosphate.
So
PRP
it's not in the pathway, it's not in the de novo pathway. Like, we can't see it, right? I'm
is there.
just trying to.
Is there. We can't just see it. Do you understand? It's there.
Okay.
You know, it's a
Is the
long
one
one.
before the IMPRP?
Yes, it's long go. It's long go. It's not immediately before IMPO. It keeps going,
Okay.
going, going, go. It's a long pathway. It's a very long one
Okay. Before we shall get to IMP, sha.
before we
But
get
it's a
to
very
IMP.
important step. Let's just note it.
Yes,
Okay.
because it is a committed step. Once that one is formed, you don't deviate from that cycle again. It keeps going down till it's completed. That's why they call it the committed step. It's very important.
Okay.
Yes. So you see it in questions like that. They will ask you what is actually responsible for the hyperuricemia. It is not HRPGT that is not there. It is because of when the HRPG is not there, the pathway will now go towards a de novo due to the activation of your PRPP amidotransferase that drives uric acid production. So they rarely test that product, but you need to remember that enzyme. But once you remember that enzyme, you also remember the product because the enzyme is phosphoribosylate amidotransferase, like transferring an amine group to phosphoribosyl. So it just replace the pyrophosphate with amine. So you have phosphoribosyl amine. So that is it. Yeah. Okay.
So, meaning that if the question had been framed such that they were asking which of the enzymes is responsible, then it would become the amidotransferase.
Exactly. That is it. That is it. So, but the deficiency, the enzyme that is deficient is the HBGRT. The one that is now driving the pathway subsequently is the amidotransferase that is causing the hyperuricemia. Okay, so a plasmid has acquired a mutation that prevents it from replicating in bacteria. This mutation most likely affects which of the following regions within the plasmid. So a plasmid has acquired a mutation that has prevented it from replicating in the bacteria. This mutation most likely affects which regions within the plasmid.
Protein of DNA synthesis.
Exactly. Exactly. That is it. I don't know if any other person chose another option or feels another option is the right one. Or like maybe chose another one. Anybody. Do we all choose the origin of DNA synthesis?
Yeah.
Okay, that's okay. Yeah, so even by elimination you can definitely find your way around the option. So I don't think we have so much problem with respect to that. Let's just move if there's no controversy with that. um a 35-year-old man comes to the physician because of a 2-year history of slowly progressive muscle weakness of his thighs. His father and paternal uncle has a disorder involving proximal muscle weakness of the lower extremities. Physical examination shows no other abnormalities. A muscle biopsy specimen shows ragged red fibers. Electron microscopy examination of this specimen is most likely to show which of the following inclusions: intranuclear filament lysosomal mitochondrial crystalline inclusion, paranuclear filamentous inclusion, sarcoplasmic reticular inclusion.
Mitochondrial crystalline.
Yes, yes. So this is just MERAF, right? So this is likely to be
Yeah.
MERAF. So because we are seeing the rag red fibers, um, so this is one of those mitochondrial disorders, and one of those things that happen in them is that they have problem with oxidative phosphorylation because there's a mutation that is affecting production of those mitochondrial protein. So those mitochondria cannot work very well, so they cannot produce ATP through oxidative phosphorylation. So that means that the high energy requiring organs like the heart and um the brain will start failing. Will start failing. So that is what is basically responsible for majority of the symptoms. So um what the body will do is to, in a compensatory manner, proliferate the mitochondria. So there's mitochondrial proliferation. Maybe it will solve the problem, but it doesn't. It doesn't, because there's an intrinsic problem with the proteins in the mitochondria. So due to that mitochondrial proliferation, you see, these red fibers. Those are proliferation of mitochondria, especially within the muscles. The muscles, yeah. So um and at the same time, so you can only appreciate this red fiber when you look at it on light microscopy. What you are going to see on electron microscopy is abundance of those mitochondrial crystalline um, inclusions. So it's just mitochondria that is proliferating in them. That is a compensatory stuff that happens in them. So on light microscopy, you are going to see red fibers. On electron microscopy, we are going to see mitochondrial crystalline inclusions. Okay, a 62-year-old man comes to the physician because of a swollen, painful left great toe that awakened him from sleep um, uh, this morning. Examination of the toe shows erythema, swelling, and exquisite tenderness. Laboratory study shows hyperuricemia. Treatment for of with colchicine resolve the acute symptoms. Long-time therapy with allopurinol is begin. The treatment result in decreased urate biosynthesis. A diagram of the purine synthesis is shown. Which of the following labeled steps is directly inhibited by allopurinol as a result of this therapy? So, which of the following phase do we think allopurinol is going to act on?
G.
Yeah, so G, exactly. So that is what xanthine oxidase. So, what are the steps that xanthine oxidase catalyze? Hypoxanthine to xanthine. What else?
Xanthine to uric acid.
Exactly. So we should not forget that. Don't just limit it to the name that okay, this is xanthine oxidase. It's only acting on xanthine, converting it to uric acid. No, it also acts on hypoxanthine, converting it to xanthine. So if you give somebody febuxostat or you give somebody allopurinol, they are going to inhibit conversion of hypoxanthine to xanthine and xanthine to uric acid, so that you don't have any uric acid causing the problem. So that's why leishmania, you can give them allopurinol to help reduce uric acid production that is causing those gout presentation in them. Okay. Um, so you guys can see here, they've tried to summarize it. They try to summarize that pathway. Look at here. Ribose 5-phosphate to phosphoribosylpyrophosphate pyrophosphate to 5-ribosylamine. So this step is a committed step. So you taking it from this pyrophosphate to the 5-ribosylamine, that's the committed step we are talking about. So that means there's no way it will definitely get to IMP with that step. Okay, a 16 a 6-month-old boy was diagnosed with developmental delay. He has had difficulty feeding and recurrent vomiting since early infancy. He was found to have hepatosplenomegaly and lymphadenopathy during routine examination at 3 months. Examination of a biopsy specimen of the bone marrow shows numerous foam cells. A defect in which metabolic pathway is a cause of this disorder. So, what do we think is the diagnosis here, even without looking at the option?
Gauchard.
Hello? What did you say?
I said gauchers, like all those.
Yeah, but
Am
it's
I the
not
wrong thing?
Gaucher's. It's not Gaucher's. Why? Look at the cells that they are seeing. Bone marrow showed numerous foam cells. In Gaucher,
Okay.
you are going to see Gaucher cells.
That's Nema Pikabi.
Yes. So you remember all those cells, globoid cells in Krabbe, you know,
Mm-hmm.
um,
Yeah.
Gaucher cells in Gouch. They
Gaucher.
might not
Yeah.
want to. They might not want to put Gaucher cells there because it
Gaucher
gives it
cell.
away. That's a clincher. It gives it away. So they might want to say wrinkled piece of paper, something that looks like wrinkled piece of paper.
Tissue paper. Mm-hmm.
Exactly. So that would be the Gauchers. Then the last one is the foam cells for Niemann-Pick. Then you remember those three pathways that lead to ceramide. So what is accumulating first in Niemann-Pick?
Myelin.
Yeah, so sphingomyelin. So we talked about those three things that breaks down to ceramide. So we talked about sphingomyelin from the right going to ceramide, our galacto cerebroside going to ceramide from the left, then from the up side that's the glucocerebroside. So glucocerebroside, galactocerebroside, and sphingomyelin should be broken down to ceramide. So if you have failure of sphingomyelin going to ceramide, that is problem with sphingomyelinase, Niemann-Pick. So if galactocerebroside cannot go to ceramide, galactocerebroside, that's our Krabbe. If glucocerebroside cannot break down to ceramide, that is our Gaucher. So you have accumulation of those upstream products, and we know the way they present. So um we said Gauchers, yeah, Gauchers can also present like this hepatosplenomegaly, but it's just that the cells that you see there will not be the foam cells. Mm. So that is that. We should remember the Cherry spot for Niemann-Pick, hepatosplenomegaly that separated from Tay-Sachs, progressive neurodegeneration, developmental delay, and all those things. That's what you see for your Niemann-Pick. In Tay-Sachs, you see similar thing, but there's no hepatosplenomegaly, and the enzyme that's deficient is hexaminidase. For metachromatic, you don't have movement from sulfatide to galactocerebroside. So you cannot break down sulfatide to galacto. It is galacto that will now move to ceramide. So if it cannot move from the sulfatide to the galacto due to absence of aryl sulfatase A, that is metachromatic. So that one just is very toxic to the neurons. Those sulfatides are toxic to the neurons. They impair myelin formation. So there's demyelination of the central neurons as well as the peripheral neurons. So the person can have damage to peripheral neurons, weakness, neuropathy, damage to the central neurons, ataxial, demential, seizures, so many things. Problem with the cognitive stuff, all those things. Then Krabbe is now when you cannot move it from the galacto to the ceramide due to absence of galactocerebrosidase. So, you have demyelination too. There is damage to oligodendrocytes, there's damage to the optic nerve, so optic atrophy. They talk about what else again? What else again do you have? So there is peripheral neuropathy. There is, damage um, to the myelin because of destruction of oligodendrocytes. There is, globoid cells accumulation. There is optic atrophy. So once you are seeing that, and of course they will tell us the upstream substrate that is accumulating. So if you are saying that it's galactocerebroside that is accumulating, we know this is likely to be Krabbe. Then the one that's coming from hump, our GM2 going to GM3, that's the Tay-Sachs. Then um uh our cerebral side that's supposed to be degraded, you know, to the downstream. What's the downstream one for uh for our Fabries? Fabries, you are supposed to remove galactose. We are supposed to use galactosidase A to remove a molecule of galactosidase from our ceramide trihexoside. That ceramide trihexoside, the way I remember it is that ceramide trihexoside is just containing ceramide with 3 exos sugar. It contains 2 galactose and 1 glucose. 2 galactose and 1 glucose. That's the trihexoside. Ceramide plus a trihexose. What is the trihexose? 2 galactose and 1 glucose. So in people with the Fabry's, what you want to do is just to remove 1 molecule of the galactose. That's just what you are supposed to do, so that you'll be left with your glucose and the ceramide. So that's likely to be glucocerebroside. I think that should be the that should be the pathway where it's going. I think I've forgotten that part. I think that's what it should be. Let's just check. Or do we
You're
have any?
supposed to give, yeah, ceramide trihexoside or the global something, sure.
No. It's not supposed to give that. Like, you are supposed to degrade that. I think that's what you are supposed to degrade, though. Are you sure? Give it. No, that is what is accumulating now. That's what is accumulating.
Yeah, that's what is accumulating. Yes, that's what is accumulating.
Yeah, so that means that it should have been degraded to something. So I think the
Okay, that's true.
intermediate, that product should be glucocerebroside. That's what I'm thinking, like, based
It's
on.
glucose.
Okay.
Hello?
It's glucocerebroside.
So
That's
thank you for.
ceramide. Yeah, ceramide trihexoside to glucocerebroside.
Yeah, so thank you very much, Dr. Moravia. So that is the way it works. So you guys should just learn it that way. Like, ceramide trihexoside contains 3 exos. Ceramide is 3 exos. So what are the 3 exos? 2 molecules of galactose and 1 molecule of glucose. So that means that once you cleave off, and the enzyme that is deficient in Fabry's is galactosidase, your alpha galactosidase. That means that you cannot take, you are supposed to take off the galactose. So if you will take off the galactose, that means it will be remaining the glucose and the ceramide, which will join together to form glucocerebroside. That's it. But if you cannot take off the galactose, that means that it will still, contain the 2 galactose and the glucose with the ceramide, which will be your ceramide trihexoside. So that
Hmm.
ceramide trihexoside is very easy to remember than the glucose or something global, but you still be seeing the trihexosyl, glucose. You know that, okay, this is still
Mm-hmm.
ceramide. I don't know if you guys get. Sorry, guys, I can't remember
Yes,
the name
yes,
very well, like, because
yeah.
I
But
can't be. Eh? You said what, Doctor Zulia?
I wanted to ask that is it important for us to know what it gives off, like the product that is supposed to give? Can we be
Else going
questioned
to
on that?
honestly, must we know it?
Yeah, the reason why I mentioned it, guy, was that with that I can be able to recall the enzyme. That's the way I learnt it. Most likely, I don't think they can hack. What they can hack is the metabolite that is accumulating, not the one that is, being produced.
The powered reaction.
Yes, but you know that if you remember that metabolite now, you'll be able to figure out the enzyme that is deficient. I don't know. It works for me, but you know,
We palm it like in a palming way.
no, Dr. Ziliad, if you permit, see, there's possibility of you forgetting. That pathway is not very easy to recall like that, too, unless you have,
Me, I don't
mastered.
even know pathway. Like the way I say it, I know that there's a pathway, but me, I not know that there's pathway like that connects everything. I just know the enzymes and what is accommodated. Like it's like I
Okay,
just learned it according to the table. You understand?
okay, yeah, I get. So if it works, then that's fine. Yeah. So the answer here is sphingomyelin. Sphingomyelin. Okay. So a 2-year-old boy present to the pediatrician um with fever, facial tenderness, and a green foul-smelling.
Hi, sorry, is that E? It's for
Yes, yes. So
thank
something. Sorry, for something. A 2-year-old boy present to the pediatrician with fever. Please, guys, I don't know. Some people might have got it wrong because of this for something. No, did we still pick for something?
no.
Ah, sorry. Oh my
No.
god. Oh my god. It was when we are trying to do that rearrangement that we made that mistake. So sorry about that, guys. I'm so sorry. I know that majority of us would have gotten it. Yeah, so sorry. A 2 year old boy,
Imagine.
sorry, a 2 year old boy presents to the pediatrician with fever, facial tenderness, and a green foul-smelling nasal discharge. The patient is diagnosed with sinusitis, and the physician notes that he has a history of recurrent episode of sinusitis. X-ray of the chest is ordered because of the fever. It revealed some dilated bronchi and shows the heart situated on the right side of his body. A congenital disorder is diagnosed. Which other finding would this patient most likely have? So what's our diagnosis from here?
Primary ciliary dyskinesia.
Exactly. So this is primary ciliary dyskinesia, okay? Otherwise called the catagena when there's
Cartagena. Yeah.
so what is the so in addition to having sinusitis, they can have so many other problems. They can have problems with their hair because there's affectation of the cilia within the Alsatian tube. So they can have otitis media. They can have sinusitis. They can have problems with the heart due to the fact that the cilia is also important in maintaining orientation and patterning. So we might have to have structure that's supposed to be on the right being on the left, particularly the heart. So the heart that's supposed to deviate towards the left is pointing towards the right as dextrocardia. It's also important in the motility of the fallopian tubes, to propel the egg towards the uterus for implantation. So in people with Cartagena, that ciliary problem, that ciliary motility action is lost. So they cannot propel the egg towards the um, uterus. So there's a high chance of them having ectopic pregnancy because you just have fertilization of that egg within the fallopian tube, and that's where it's going to mature. In males, the tail of the sperm also requires the cilia for its movement. So if uh if they don't have that cilia, you can't have propagation of those um sperm cells, and there'll be infertility. I've even said the answer. I wanted to ask her. I know we know it. So what's the answer now? Infertility, yeah. So this is
But
catastrophic.
may I have a question still?
Okay.
Even though I know the answer is infertility, can the answer be elevated blood sugar considering the age? Can't it be? Like
So
considering the fact that it will affect the pancreas and all that.
no, Dr. Zila, this is not cystic
Okay.
fibrosis now. This is not cystic fibrosis.
Well,
Yeah, so if it's cystic
okay.
fibrosis now, you can have diabetes. Yes, it's possible. Yes,
And then defective chloride transport will not be there again because both of them are in the same
exactly.
disease.
Yeah.
And
Okay,
then
that's true.
C will not be there too.
Mm-hmm.
No,
That is it.
that's true. Okay.
Yeah.
So cystic fibrosis, the problem for the infertility thing is what?
Absent vas deferens.
Absence of difference. Let me just throw this random question. I don't know if we can remember. So what is the screening test for Cartagena? What is the screening test for Cartagena? Anybody?
Is it the it's not the X-ray, is it?
No, it's not the X-ray. You want to screen.
Is it absent
Nitric
dining?
oxide.
Yes.
Yeah.
Nitric
Ah,
oxide,
is that
okay.
Dr. Wako? Dr. Wako, is that you? I think I can pick your voice. Dr.
Yeah.
Wako. Okay. Yeah, so that is nitric oxide. So people with Cartagena have low nitric oxide. So there are so many postulations as regards why. So some studies said that it's due to the fact that cilia is important in synthesizing nitric oxide. So people that have ciliary dyskinesia, they cannot produce any nitric oxide. So if we try to analyze using some machine, some spectrophotometry machine, you analyze the nitric oxide component of their breath, it is very low because of that. Some people said because of the fact that they are predisposed to having so many airway reactions, the nitric oxide will have been taken up by the reactive oxygen species to form reactive nitrogen species to drive that inflammatory process. So you guys should just know that nitric oxide level is reduced in them. And very important, based on experience, they can ask us what is the protein that is defective in Cartagena. So what's the protein that is defective in Cartagena?
Dynein.
That's
Dynein.
dining.
So you watch out for dynein. you watch out for dining. You watch out for dining. Although they might not put dining there, so it might be another thing. So what is the dining trying to attach to? Sorry, I know that I've confused you guys. What I mean is the dining. The dining is more like an ATPase that helps us produce ATP so that you can propel those ciliary propagation. Um, it attached to something within that cilia. Do you remember? Okay, so it attached to the microtubule A. You guys remember that cilia is arranged in doublet, 9 doublets, 1 singlet, two singlets, 9 doublets. Let me show us that diagram. So the dynein attached to the microtubule. So if you guys don't see dynein, you are looking for tubulin. So please don't forget that, please. um I think it's
Page
before
40,
40,
page 47. Page
47.
47.
Okay, thank you, Dr. Adu. 47.
Sorry, for 2002, not for 203.
203 guys, 2023. Dr. Adu. Okay, I think it should be very similar in terms of the 47. 47. This is 57. Oh, this is my computer.
It's page 47 of the actual book, like the actual book, not your computer number. Do you understand? So look for the
Okay, the actual
uh-huh.
book. Yeah, like the one hop, right?
Yeah.
Yeah. Thank you, Dr. Francois. Okay, yes. So this is it. So we can see this doublet here. So yeah, there are 9. 1, 2, 3, 4, 5, 6, 7, 8, 9. So we can see that the dynein is attached to microtubule A. Can we see this red thing attaching to this green guy? Exactly. So that dynein arm is what generates ATP that allows propulsion of or to contraction of this microtubule so that they can move the cilia. So what is defective in Cartagena is dynein. That's the problem. But that dynein attached to microtubule A. So at the same time, you might have impairment of action of microtubule A or tubulin A. So that can also be there. So we should watch out for that. Okay. Um, a 28-year-old man has recurrent pancreatitis associated with familial triglyceridemia. Administration of which of the following drug is most appropriate? So, of course, the answer is there. I should have asked those without, the answer is there. So, so we should give a drug that decrease VLDL. Which other lipid you guys?
Why?
Yeah. So, Dr. Francois, I should be asking you guys that. Dr. Luatobi, do you want to answer? Dr. Luatobi or Dr. Zuliat? Dr. Kenneth? Dr. Kenneth? This one that anybody is not answering me. Hello?
I'm not sure. I'm not sure.
Hello,
Sorry.
hello.
Okay. Yes. If you guys remember, the lipid that contains the highest amount of triglyceride, they are the chylomicrons and the VLDL. That is it. The action of VLDL is to deliver triglyceride to the tissues. That's why VLDL is a bad guy. It's not that it's a bad guy, but it can cause harm because you don't want triglyceride to be littering around your blood and be, depositing everywhere. just like LDL. LDL too will be moving around depositing cholesterol to the tissues, the blood. That is why it's really bad. It should not be too much. You need it, fine, but it should not be too much. So if you have elevated VLDL, it's bad because you have high amount of triglyceride in your body. So the VLDL is a form that the liver packages triglyceride. So triglyceride is packaged within the VLDL, from the liver. The triglyceride that we are getting from our diet, the one that we are getting from our diet will be absorbed from the intestine and it will be packaged into chylomicrons. That one is dietary triglyceride, chylomicrons. So within that chylomicron, you are packaging your dietary triglyceride and your cholesterol, but you are esterifying that cholesterol. So there are some enzymes that does that esterification, but we don't need to learn those guys. So they will esterify those cholesterol and package everything into chylomicron. So three things you have majorly in chylomicron: you have your triglyceride, you have your esterified cholesterol, and you have the fat soluble vitamins. You add them in vitamin A, D, E, K. They are packaged into that chylomicron. So they will now be absorbed from that intestine, into the lymphatics. What is a cofactor that drives that absorption? Anybody do you remember? The apoprotein.
B48.
B48, yes. So the B48 allows the absorption of the chylomicron from the intestine into the lymphatics, then from the lymphatics to the venous blood, find its way into the blood. That is the action of chylomicron. What now happens to that chylomicron? So chylomicron will now get acted upon by lipoprotein lipase. So what lipoprotein lipase will just do, that one is in the blood. It just cleaves off all the triglycerides in chylomicron. That's what it does. Cleaves all them into fatty acid and glycerol so that you can utilize them wherever you need them. That is it. What will be remaining? The esterified cholesterol. That esterified cholesterol that is present in the chylomicron, together with the chylomicron, we call them the chylomicron remnants. The chylomicron remnants. So those ones will now go back into the liver and be taken up by the liver. So there's an enzyme that allows absorption of those chylomicron remnants. Do you remember the apoprotein that is responsible for that?
Let's see.
Mhm.
No, it's
Into
not
the
C.
liver, abi?
No, it's not. Okay, yeah, so I should have mentioned the activity of C. Now, you guys remember that we talked about um, lipoprotein lipase cleaving off triglycerides from chylomicron. So the apo enzyme it needs for that is apoprotein C2. C2 is what assists it with that. So C2 assists lipoprotein lipase to
So E
go.
then.
Yes, yes, it is E. It is E. So the E apoprotein now helps the liver take up the chylomicron remnant. So it takes, the chylomicron remnant from the chylomicron. So that is apoprotein E. Apoprotein E. That is it. That is it. So some of those cholesterol are now packaged inside LDL. So they are packaged inside LDL, they are released into the circulation. So attached to the LDL B100. So that is it. So with that B100, they can be taken up, by different tissues by receptor mediated endocytosis to utilize the cholesterol. But when it becomes too much, it will start clogging all the vessels and start forming atherosclerotic plaque. So what I just want you guys to pick from there is that if something elevates triglyceride, you are not looking at atherosclerotic plaque. Triglyceride have no role in formation of those plaque. It is the cholesterol within LDL. Those are the bad guys that are called atheromas. So anything that accumulates triglyceride will majorly cause those xanthomas. So just xanthelasmas, formation of those lipid plaque within the eyes, the Achilles tendon, the corneal, and all those things. That's then
Dr.
pancreatitis.
Babali, sorry, can you repeat that last statement about the chylomicrons cholesterol? I didn't really get it.
Okay, you know that we've
And
said
that's
that.
very nice.
Yeah, so when you cleave off, when lipoprotein lipase in the presence of apoprotein C2, so lipoprotein lipase in the presence of apoprotein C2 cleaves off triglycerides from our chylomicrons. So what will be remaining in the chylomicrons will just be some of those cholesterol, because lipoprotein lipase does not work on cholesterol. So it will just carry itself with the cholesterol and go to the liver. It will be taken up by the liver because of its apoprotein E that it contains on its surface. So it will take them. Now, some of those cholesterol can be packaged into LDL and be secreted from the liver into the blood. And that LDL too contains B100 on its surface. So it is through that B100 that it is taken up by the tissues. So it distribute cholesterol to all the tissues to synthesize different things they want to synthesize. Maybe they want to produce lipid hormones and all those things. They will use the cholesterol. You can use cholesterol for so many things. So, but when it's too much, it starts accumulating within the blood and it can cause atheroma. So it is LDL, the cholesterol in LDL, that causes atheroma, not triglyceride. Triglyceride and cholesterol are different form of lipids. Triglyceride don't cause atheroma, but cholesterol, LDL, in LDL does it, because LDL doesn't contain triglyceride. If it contains maybe small, it doesn't even have triglyceride. It is more of cholesterol. While VLDL is more of triglyceride and little cholesterol. Do we understand it now, Dr. Francois? Do you get what I'm saying?
Yes, Clara. Thank you.
Yeah. So
Yeah.
that is why if somebody has familial hypercholesterolemia, that means that cholesterol is abundant. That means that you cannot cleave our triglyceride from cholesterol. That is the problem. From chylomicrons. That is the problem. So what enzyme is involved in cleaving triglyceride from chylomicron?
See.
Dr. Baba, I didn't understand that part now. We said when we have hypercholesterolemia,
No.
that means we cannot.
Chylomicronemia. So that's what I
Okay.
said. So that means that triglyceride and cholesterol, they are both abundant in the chylomicron, right? Because we need the
Okay.
lipoprotein. Oh God! Because we need the enzyme to cleave off triglyceride from the chylomicron. So what is that enzyme?
See.
No. I'm not asking
Apostate.
for the lipoprotein.
Lipoprotein lipase.
Yes, lipoprotein lipase, which requires apoprotein what?
C2.
C2. So that means that we can definitely say that hyperchylomicronemia can be associated with deficiency of lipoprotein lipase or absence of apoprotein C2. Now, what do you guys think would accumulate in someone that has hyperchylomicronemia? What do you guys think will accumulate in that person?
Triglycerides.
And
Apostate.
no,
I don't know.
when we are talking now, we said triglyceride will be packaged into the chylomicron, and we also said that cholesterol will be esterified and packaged with it. Hmm? Do you guys remember when I was saying you
So
package
that means you're saying esterified cholesterol is what we're supposed to say.
esterified cholesterol too will be there? Hmm. Now, if we check the presentation of hyperchylomicronemia, you guys will see that you have formation of atheromas, right? Are we having formation of atheromas there? Let's be sure so that we'll know that we are not moving stupid. Those hyperlipidemia can be very funny.
There is no increased risk for atherosclerosis.
There's no repeat
Is it
atherosclerosis.
for, there is 1 and 2?
No, Dr. Ziliad. It is hyperchylomicron that we are talking about. That one doesn't have 1 and 2.
Okay. Okay, sorry.
So
Eh?
yeah, check. What is there?
Liver posture to the Okay, yeah, there's no increased risk for atherosclerosis.
Okay, so what is accumulating?
Chylomicrons and CG and cholesterol.
Okay, so sorry, let me get there myself. I just want to look at it. Sorry. Yeah, so exactly. So yeah, so although the cholesterol is accumulating, but it's the esterified form. So that's why it doesn't confer this atherosclerosis. It's the one that is released from the LDL that actually mediates that atherosclerosis. But we can see that it's not only triglyceride that is accumulating. We can see that cholesterol too is there. We can see. So everything, your chylomicrons, your triglyceride, and your cholesterol. And the problem here is lipoprotein lipase or ApoC2. And triglyceride accumulating majorly causes pancreatitis. Then it can deposit within the liver, the spleen, and cause xanthomas, just like we talked about. So it doesn't cause atherosclerosis. And because of the triglyceridemia, you see the creamy, so it looks very whitish because of those accumulated triglycerides. Yeah. So anyone that involve accumulation of the LDL cholesterol, that's the one that will cause atheroma. Okay, triglyceride has no role in causing atheroma. Yeah, so let us let us continue so that we don't spend too much time here. So with what we have said so far, it makes sense to say that anything that brings down chylomicron. Hello.
I'm with
Yes,
you.
Okay,
why?
yeah. So anything that brings down chylomicron and VLDL can help us take care of triglyceride, because we've said it that you know um um VLDL and chylomicrons are the lipid molecules that contain the highest amount of triglycerides,
Mm.
chylomicrons and VLDL. So VLDL is actually produced by the liver itself, packages all those some triglyceride itself into those VLDL and some cholesterol too, but it contains high amount of triglyceride, just like chylomicron. It's just that the chylomicron is getting its own from the diet, while the liver is producing its own and packaging it into VLDL so that it can get to the tissues. So that is why decreasing VLDL can help to treat hypertriglyceridemia. That's why if you guys look at the type 4, what is the pathophysiology of type 4 hyperlipidemia? Anybody? Type 4.
Overproduction of VLDL, I
Exactly.
think.
Overproduction of VLDL. So that is why the triglyceride is elevated. So why not decrease VLDL? Once you decrease VLDL, you take care of the hypertriglyceridemia. So you guys should not forget what we've talked about.
Yes, so, no, but sorry, please.
Doctor,
Yes, I'm listening.
Is it the esterification of the cholesterol in chylomicrons that makes it like have low risk, I mean no risk of atherosclerosis?
Yes. So that is what I believe. So
Okay.
the esterification, yes. So it's not really readily available to be forming those atheromas. Yes. But it contains cholesterol too. It contains cholesterol. You can see that cholesterol is also accumulating, Dr. Precious. You can see. Hello?
okay,
Yeah.
Doctor Babale,
Yeah, Dr. David.
yeah, I understand everything you said, but I was thinking, why not increasing HDL, since HDL, will be the one like donating the ApoC2 and ApoE,
Yeah.
for
Yeah, I was thinking the same.
I I get what you mean, but I don't think increasing HDL can, help you take care of it. Because because yeah, I think I understand what you're saying, but I don't think it has actually shown. What I've read about this lipoprotein guys is that although if you have HDL, it's protective, yes, but studies have shown that increasing the level of HDL doesn't actually offer any benefit. Don't worry. When I Which is very logical based on what you have said. What you said is very logical, but I don't think it works that way in vivo. It doesn't work that way. When we are done now, I'll try to send you maybe an article that I read like that. So if even if you see that somebody's HDL is low, increasing it doesn't actually confer any benefit towards cardioprotective health. It doesn't. It doesn't. But it's good to someone to have elevated HDL for what you have said. But increasing it doesn't confer the benefit. The problem is what you can do is to reduce what is likely to cause the problem, not increasing HDL. So that is that, Dr. David. It's just a very tricky way of
thank you.
confusing somebody. Increasing ADL doesn't actually help. It doesn't. It doesn't.
All
Yeah.
right, thank you very much.
You're welcome. So Patient with mucolipidosis type 2 lacks phosphotransferase that is required for formation of mannose-6-phosphate residues that are normally attached to enzyme destined for the lysosomes. The mannose-6-phosphate sorting signal is normally added to proteins in cis-Golgi. Which of the following process most likely occurs through the lysosomal enzymes in the patient? So what did we say happens to those lysosomal enzymes in mucolipidosis type 2? Guys, we are keeping quiet too.
The serum to increase in the serum.
Exactly. It will increase in the serum. They will not stay within the lysosome. They will move out of the cell, across the cell membrane into the serum. So that's why option D is the correct one. Did we choose any other option?
Yes,
Anybody?
so it's not that I'm just understand.
Okay, which one did you pick?
But why
pick
would
C.
it be secreted from the cells? Because that confused me really.
Yeah.
Because I'm like, it should be in the cytosol. Is not the same as secreted from the cells. Do you
Exactly.
get?
Now, Dr. Latobi, if it's in the cytosol, it will not find its way into the plasma because cytosol is intracell, is within the cell. It's not within the blood. The blood perfuses the tissue. The tissues are made up of cell. So it is supposed to move out of that cell across the cell membrane into the blood. That's why I always say it. I always mention it that it is moving across the cell membrane. Once something moves across the cell membrane, it has left the cell. It has left the cell. It moves across the cell membrane into the serum. So, Dr. Luatobi, if it's within the cytosol,
No, I actually picked secreted from the cells. Do you get? Because I know rough is different. So I picked secreted from the cells. But I'm like, that answer doesn't really, it's easily distract.
Yeah.
How do I put it?
Yeah,
Yeah,
it
like it's
distracts.
not.
Yeah.
It doesn't
Yeah,
nail you.
because
It doesn't
somebody
nail
that would just pick, okay, where would it be? We don't know.
you.
And that
Yeah.
was why I picked CO because I knew that she be to shall leave where it was before. And I'm telling you, that's why I read that. Well,
Like
let's go back to the rough endoplasmic reticulum.
Dr. Zilia, if you can pick C, then we
Yes.
can pick E.
Mhm.
Because in all of those guys, it is not in the lysosome where it should be.
Oh, that's true.
Yeah,
Mitochondrial
that's true.
in the mitochondria. That's true.
But the take home here is that it moves across the cell membrane, it leaves the cell entirely. It leaves the cell entirely and go into the blood. That is it. So yeah. So I remember one day I was trying to explain this particular question, and everybody was just quiet that day. In fact, let me just see if we can actually figure it out. So in patients with adenosine deaminase deficiency.
Please, Dr. Wale, before we move on, please, sorry, I don't understand that last question. I mean, I picked in rough in the plastic reticulum because they will go back to where they're coming from now, Abi?
No, they will not go back to where they are coming from. Oh. They will go to the blood.
That's what I thought.
They will leave the cell. That is why, guys, that is why one of the clinchers to nail this mucolipidosis is what? Elevated serum level of those guys. Elevated serum level of the enzymes. It is elevated in the serum because they leave the cell to enter the blood. That is it. They leave the cell to enter the blood. If it's accumulating within the rough endoplasmic reticulum or the mitochondrion, it's still within the cell. It's not within the blood.
And there's no way you can measure that. Okay, I think I got to.
Do you get it?
Yeah, I think I get now. Like we can't say it's plasma. Like I don't know. I feel like if it's in the rough the plasma school, you can't be able to measure it in plasma. That's way. That's
You're
what
not
I'm
able to
putting in my
measure it in
head.
plasma. You're not able to measure because plasma is water. Plasma is water.
Yeah.
Plasma has no cell. It's water. So majority of plasma is water.
Okay. Thank you.
Yes, you're welcome, doctor. So in patients with adenosine deaminase deficiency, there is a 50-fold increase in DATP concentration in T cells. This increase the increased DATP inhibit which of the following So the increased DATP inhibit which of the following compromising DNA synthesis. So what do you guys think is the diagnosis here like this? Anybody?
Severe combined immuno.
Yes, nice one, Dr. David. This is severe combined immunodeficiency syndrome. which is affected with adenosine deaminase deficiency. So now let us see. So what is the enzyme that will be rendered inactive without looking at the option in them?
Ribonucleotide
Yes, you
reductase.
try.
Enzyme, is it not?
Oh,
You
okay, okay. Because I just got
Okay,
back
I
to
was
the
like,
question.
I
Okay,
didn't
yeah,
understand
the
your question right. I
increase.
was like, is it not add that? Like,
Okay,
what are you asking again? Okay, so
okay.
you were asking that. Okay, I
yeah. So
get your
this is the
So
question.
enzyme
it
that
render ribonucleotide reductase insignificant because of
Okay.
negative feedback, right? Yeah.
Yeah,
Mhm.
yeah.
Nice one. That is it. So that negative feedback of a thing. So in someone with adenosine deaminase, they cannot deaminate adenosine to IMP. So before I move, let me quickly mention something here. Now, um, the reason why. Do you guys remember um glycogen storage 5? This guy, Mercado disease.
Myophosphorylase.
Yes,
My
myofasciculate.
phosphorylase.
Yeah, you guys remember that they have there's something that describes them. They said there's reduction of one metabolite and there's accumulation of one metabolite. Do you guys remember that? I want you guys to tell me. So which one is accumulating? Which one is defective? This one that everybody is
Please.
just saying. Okay, so so lactate do not accumulate. You are expecting a rise in lactate when you are exercising the muscles. But in people with the malphosphorylase, there is no elevation of lactate, but there's elevation of a mean amino ammonia. Do you guys remember now? Ammonia rises, but the lactate doesn't rise. The reason why the ammonia is rising is because of this similar enzyme of a thing. Now, the quick way they can quickly generate energy, they will try to combine two molecules of ADP together. So they combine two molecules of ADP and they will get one ATP and one AMP. They'll get one ATP and one AMP. Now that AMP will now be catalyzed by a similar enzyme, similar to this adenosine deaminase. We call that one adenylate deaminase. It will deaminate um, the AMP to form IMP. That is it. So that IMP can now go to other cycles to generate ATP again. If you guys need the image, I can send it to you guys so that you can understand it. But the take home there is just that,
Yeah, that would be nice.
yeah. So I'll send it. I'll send it. So the take home there is just it is due to the ADP combining together to form ATP and AMP. So two ADP combines together to form one ATP and one AMP. You deaminate the AMP. Once you deaminate it, you remove ammonia. So that's why ammonia accumulates in someone with our glycogen storage file. We should not forget that. Yeah, so let's go back to this one. If you have adenosine deaminase deficiency, that means that you cannot deaminate, um, you cannot convert um, adenosine to uh, to IMP to ionosine. You cannot convert adenosine to ionosine. But to really understand this process, it's not actually the adenosine that we look at, because what is catalyzing adenosine will also catalyze deoxy form of adenosine. It is the deoxy form that we actually need to remember. So it cannot catalyze deoxy adenosine to deoxy inosine. So that means that deoxy adenosine will accumulate, deoxy AMP will accumulate, deoxy ATP will accumulate. So once the level of DATP accumulate, the body will think that okay, it has a lot of deoxy enzymes, the deoxy form of ATP. That means that it doesn't need to be reducing ATP to deoxy ATP again. It doesn't need it because it is that reductase enzyme that actually converts ATP to DATP. So it will shut off the activity of ribonucleotide reductase that will convert all those ATPs, your CTPs, your TTPs to their deoxy form. And you guys remember that the deoxy form is responsible for formation of DNA, while the normal form is for RNA. The fact that we are calling it deoxy, that means deoxyribonucleotide, deoxyribonucleic acid. That's what makes it DNA. Our RNA doesn't contain deoxy form; it contains the normal form. So that means that you cannot form, once you shut off the activity of your ribonucleotide reductase, you cannot form deoxy CTP, you cannot form deoxy-TTP. You cannot form deoxy-GTP. And those guys are also important, just like deoxy-ATP to form DNA. So that means that there will be compromise of DNA synthesis in these guys. It is particularly affecting the T cells because the T cells have been shown to have the highest activity of ADA. The T cells have the highest activity of ADA. So it predominantly affects the T cells. You cannot synthesize DNA in T cells. So that means there will be reduction in the level of the lymphocyte, causing immunosuppression. So what form of immunosuppression do we see? We call it severe combined immunodeficiency syndrome. Once we get to immunology, we are going to understand SCID very well. So do you guys get the long story that we have talked about?
Eventually.
Eventually. So
Doc-
so do
Dr.
people have
Eventually.
any
Is
Wale,
there at least somewhere, sha?
eh?
it's up to the rule because I don't know.
Okay, now
This
let us go to that pathway. We need to see that pathway. That is it. It's because of my system that is dulling my cursor. I don't know what's wrong with my cursor this morning. It's not it's not acting normal. So let me try and go back to that image. That's what I was saying. That day now, if we have settled it once and for all, we won't have the cost to be going over it now. You guys just told me, yeah, you understand, so that I can move. That was what happened. You guys count me. So um sorry. I'm coming. Why is it going down now? Okay. So um yes. So this is it. Now, can you guys see this guy? This adenosine going to inosine. Can you see this?
yes.
Exactly. So that is what the HADA does. So it is what converts adenosine to inosine. But in addition to adenosine, it also converts deoxyadenosine to deoxyinosine. You know that you can see it here. ADA is required for degradation of adenosine and deoxyadenosine. Can you see that, Dr. Ash?
Yes.
Yeah. So that means that if you are looking at RNA, it will be adenosine. If you are looking at DNA, it will be
We do
deoxyadenosine.
everything.
Now, what does it take it to? It will convert them to inosine. So if that enzyme is deficient, that means that deoxyadenosine will be accumulating, right? So
Yes.
that means that all the molecules that are upstream to adenosine will keep accumulating because
Hmm.
the body will not want to produce more of the adenosine again because it's already in abundance. You are not converting it to inosine, so it will keep accumulating, and that will make the substance that are upstream to it accumulate too. And what are these? AMP. I know that AMP is from ADP. ADP is from ATP. Do you get it? You know that if you have reduced level of adenosine, what do you think will happen to the level of AMP? It will be reduced too because you have more AMP trying to get converted to adenosine. But here you have elevated level of adenosine. That means that all the substance that are forming adenosine will keep accumulating because they will not get converted to adenosine again because of the feedback, just like Dr. Toby mentioned. Do you understand? Do you get it, Dr. Precious?
Yes, yes. So okay, I think it's because I was confused where AM this AMP is coming from. You said it's coming from
Yeah,
ATP. Okay.
yeah, like you know that nucleic acid contains no, it's not actually from no, I'm just saying that actually it's actually from nucleic acid directly because those guys contain AMP, they don't actually contain ADP or ATP. Those ones are energy molecules. Sorry,
Okay.
I'm just trying to give illustration. If you break down
Okay. Okay.
nucleic acid, it is AMP. You can have CMP, GMP, IMP, TMP. You don't have ATP. It's not ATP. It's not ATP. ATP is energy. Yeah. So it's actually the AMP.
So that's why I'm confused. Where is this DATP coming from? Elevated DATP.
Yeah. You know that. Fine. Your nucleic acid is the one that is breaking down to AMP. But you know that ATP too, when you are utilizing ATP, you know, if you break down ATP, you get ADP now, right? If you break down ADP, you get AMP. Do you get?
Yes.
Ehen.
Yeah.
So because of the fact that AMP too is accumulating, AMP from other sources too will be affected. Do you get it? Like ATP and AMP. Do you understand? Hello?
Yes. Yes.
So
I
so
understand.
that is the problem. That's the problem. Now, because of the fact that all these AMP, your ADP, your ATP, they are accumulating. Although the major metabolite that you need for formation of your nucleic acid is actually AMP. It's the monophosphate form that is actually very, very important. So I think so. Yeah, it should be the monophosphate. Yes. So um so now you're having now I'm not saying that we should look at if you look at it from the angle of DNA, that means that we will change this adenosine to deoxyadenosine, not adenosine alone. Do you get it? It will be deoxy because it's DNA that we are looking at.
Yes.
It catalyzes both of them. So if you have accumulation of deoxyadenosine, you have accumulation of deoxy-AMP, deoxyl, ATP, ADP, sure you get. Now, that one will now switch off the activity of ribonucleotide. You know, the reason why we are getting to the ATP is that ATP is the one that actually influences this ribonucleotide reductase. So if the body sees that ATP has accumulated, ATP is not in the one in nucleic acid, fine. But if the body has seen that DATP has accumulated, it means that it will just recognize that as a reduced need to reduce ATP to DATP. Do you get it?
Yes. Yes. Yes.
So if it sees that DATP is abundant, so that means that we don't need to be reducing all our ATP to DATP again. So let's cut that out. So if it shuts down that means that you don't have that enzyme being active again. But you remember that it is that same enzyme that is also important in conversion of your AMP, your ADP, to and the other ones, your CMP, your GMP to their reduced form. So that means that you have reduced presence of those other ones like your CMP, GMP, TMP in their reduced form. Not only AMP now, because it is important in reducing all of the other ones too. Do you get it? So you have reduced form of your reduced CMP, reduced TMP, reduced GMP. Do you get it? Because you have shut down the activity of ribonucleotide reductase.
Yes. Yes.
I
Well,
think
I'm
that
just wondering why they didn't put why the word the enzyme ribonucleotide reductase is not on this pathway.
which pathway? No, okay,
This particular pathway.
yeah, just it's just one of those things. But they've mentioned it like deoxy, deoxy, adenosine and adenosine is already here. So don't bother yourself about that. So all the DNA precursors be reduced because of that. It's not specific. It's not specific. So it can take care of any of the ribonucleotides. So that is it.
But if I may ask, is adenosine that is ribonucleotide reductase is converting adenosine to deoxyadenosine.
Yes, to deoxy form.
Okay.
That is it.
Okay.
To deoxy
For
form.
DNA synthesis. Okay.
For
Okay. I think
DNA
I get
synthesis. Yeah.
it.
So that is it. Okay. So this one is one of those control questions too. It's one of those control questions. I just put it there. Which of the following is present in integral plasma membrane arterial protein but absent from secreted protein? So the answer is the transmembrane region. So transmembrane region is
Wow.
you said
And I said, wow.
yes. So all these O-linked glycosylation and N-linked glycosylation, those ones are actually the portion that you find from protein that are synthesized from the rough endoplasmic reticulum. So protein that are produced from the rough endoplasmic reticulum, where do we think they go to? they go outside the cell.
Extracellular.
Exactly, they are extracellular. They go outside the cell. So that means that since they are saying which of the following is present in integral membrane and absent from secreted, that means that O link should not be part, N link should not be part. You have eliminated those ones. Phosphorylation site is nothing. What are they talking about? Signal sequence. What are they saying? So it's the transmembrane region. Transmembrane region is the part that is invaginated within that membrane. So like all these our G protein coupled receptors, they have transmembrane region that is interlooped within that membrane that can help with the signaling cascade. So once you are seeing a membrane protein, they must contain a transmembrane region. So that is it, which is not present in secreted protein because they will go and do their action. They are not staying within the membrane, so they lack the transmembrane region. So all those secreted protein need to have N-linked glycosylation as well as O-linked glycosylation so that they can properly fold and they can be stabilized. So any protein that is destined for extracellular delivery and it doesn't experience the O-linked glycosylation or the N-linked glycosylation, it will not fold properly and it will become damaged. So that is it. Okay. So a diabetic patient in a diabetic patient, presence of which enzyme facilitate this condition? So what condition is this?
Cataract.
Yeah, so this is cataract. You can see the white of person, although it's not very clear, but this is cataract. So the question now said, the question is not complete. Which enzyme most likely contributed to this complication? So what do we think is yeah? So what do we think is causing this thing? What is accumulating here?
Sorbitol.
Sorbitol. So what is the substrate that get converted to sorbitol? Glucose.
Glucose. No.
So what is the enzyme that converts the glucose to sorbitol?
Hydroreductase.
Hydroreductase. So if they can also ask us that which enzyme deficiency is responsible for this presentation, what are we now going to pick? Sorbitol dehydrogenase. That's a very nice one. Yeah, nice one. Okay. An 8-month-old boy is brought to the pediatrician by his parents because he has recently lost his ability to crawl and hold his toys. On examination, the patient is tachypneic and breathing with considerable effort. The liver is palpable, 5-finger width below the right costal margin. X-ray of the chest revealed cardiomegaly. He has a different time sitting upright and cannot squeeze the the physician fingers or the ring of his pacifier with any noticeable force. Despite a number of interventions, the child's symptoms continue to worsen until his death 2 weeks later. On autopsy, it is likely that this patient cells will contain an accumulation of which of the following substances. So what do we think this is?
Glycogen storage disease.
Yeah. So which type? Which type do you think is likely going to be?
Mercado. I'm not
No,
sure.
this is not Macadu. Look at cardiomegaly.
Yeah, because I'm like, Pompeii. Okay.
Cardiomegaly. Yeah. So, well, it might not be Pompeii. It can actually be, Pompeii might be correct because those guys actually overlap. That's it. Anderson too can be correct here because we are seeing
I wanted to
hepatosplenomegaly.
say Anderson. No.
No, say
I wanted to
Anderson.
say
Oh, is it because
Anderson.
of what happened that day? You see,
Yeah.
that day, you see, I said it. Anderson is the right answer to that question. But what if it comes out like that in your exam? What are you going to now pick? So the one that is still close to, Anderson that you can pick there is the Corey.
Oh.
So that is it. Anderson is the answer. That one is sure because you can see the fibrosis. You can feel, and Anderson is the one that's actually with infantile cirrhosis. But you can also have fibrosis too in the Corey, but it's just that it's not something that comes very early and it's not constant. But in Anderson, you have excuse me. So you have um affectation of the the liver majorly. That's the first thing. There's hepatosplenomegaly. That's the first thing in Anderson. And in addition to that hepatosplenomegaly, it can deposit in the heart, causing cardiomegaly. It can cause cardiomegaly. It can also cause fibrosis and cirrhosis of the liver. And it can cause hypotonia when it deposits within the skeletal muscles. And this guy has almost everything. He's not able to crawl. He cannot move. He's likely to be hypotonic. There's hepatosplenomegaly. There's cardiomegaly. So, it's likely to be one of those. It's likely to be the Anderson. So what's the problem in Anderson? What's the enzyme?
Glycophosphorylates. What's it called?
Yeah, so the branching enzyme, Abi.
Glycosyl-
The branching.
Yeah, the branching enzyme. Yeah.
Okay.
In Anderson,
Yeah, in Anderson.
it's not branching.
Yeah, we said
That's
branching.
branching.
We said
Okay.
that's a mistake. Like what we meant is the branching enzyme, not DE
The
branching.
branching. It is the branching, not the branching.
Yes, not the branching. The sorry, we get what you're saying, Dr. Muravia. Yes, the enzyme that is deficient in Anderson is branching enzyme. So I think that's where the mistake. When we said the branching, we actually meant the what's the word? Is it what do we call that?
Branching enzyme. We actually meant branching enzyme.
Branching enzyme. Yeah,
That was
yeah.
solve it. Yeah.
So at a routine checkup, a 7-year-old boy is found to have osteoporosis. The patient is tall, thin, with pale skin, fair hair, and flushed cheek. He has arachnodactyly, pes cavus, and bilaterally dislocated lenses, and demonstrates developmental delay with mild mental retardation. His mother is told that a child might benefit from folic acid supplementation, which is the most appropriate test to confirm the diagnosis. So what's our diagnosis here?
Marfan syndrome.
Yeah, so I know that some of us will think it's Marfan. I know, but if we try to look through the option, there'll be Marfan. We will not find it there. I now know that we'll now change our mind. So, Dr.
So it's
Oluwatobi,
now be homocystinuria.
exactly. Did you get it, Dr. Oluwatobi? Did you get
Yes,
it?
I did.
Okay,
Yes,
nice
I
one.
did.
Nice one. So,
But if there was something else there, for not just miss me like that, like hey,
yeah,
voila.
Sister,
some
it is
people might have chosen,
well.
some people might actually have chosen type 1 collagen because they will be thinking maybe Marfan is collagen disease. So, we said it that day. Marfan is a lasting problem. Fibrillin, which makes them unable to sequester these they cannot sequester the transforming growth factor beta from the what's it called, the elastic fiber. So the TGF beta damage all the elastic fibers because you need fibrillin. If you have fibrillin now, you can scavenge all those TGF and you protect those elastic fibers. But because they have problem with formation of the fibrillin, they cannot sequester the TGF beta. So the TGF beta just go and digest all the elastin, makes them present with that presentation. But what actually gave it away that this guy is having homocystinuria and not Marfan is that they said he has developmental delay with mental retardation. You guys remember that we said that intellectual disability is not in Marfan, right?
Yeah.
Yes. Then homocysteine is a form of amino acid that is very toxic to the bone. It is one that causes osteoporosis. People with Marfan don't have osteoporosis. So we should not forget that too. So that's why I intentionally did not want to put any option there that would fit Marfan. I changed some of the option myself. Now, in the option, they just put nitroprusside cyanide test. But I was the one that added this. Have you guys noticed that USMLE, you can never see an option like this / do you guys notice?
Yes.
Lie.
Thank you. Yeah, we're supposed to be crediting you
You
then.
can never
That means you
see
do not do
/
your normal way.
Dr. Baba, they don't join
Yeah, thank
MBNU.
you.
Don't
No,
join
you don't
MBNU.
get You guys should be praying that I join MBME now. Maybe I was one that put the slash for you
Honestly,
guys.
that nitroprusside, I will never, never
I'm
thought
like,
of it.
like a
Yes,
plus
Never.
side of Cincinnati, like,
exactly. So
how do they
so
relate?
but do you guys remember where we test nitroproside? Do you guys remember the system? There's a place that we use nitroproside and we have done it too.
Cyanide
Is it not
poison.
scopolamine?
No. It is
Which
in
one?
it was in 16 stone. Renal stone, 16. We use
Oh,
we use
okay.
this
Mhm.
we use this guy because what happens is that once somebody has 16 stone, you know that the 16 we are talking about is CYSTIN,
STIN.
not the amino acid, not the amino acid.
Okay.
Now,
Okay.
the way you can confirm if someone had that stone is that if you add that urine to this guy, this
Mm-hmm.
cyanide is going to convert um that cysteine
System.
to the amino acid, which is cysteine with the E. Hmm? So that cysteine will now combine with nitroprusside and form a purple color. That is it. So
Can you say that again? Sorry, Dr. Babari. Please.
So, for the nitroprusside cyanide test, it is used to confirm diagnosis of homocystinuria as well as cystinemia, like someone that has a cystine stone. The
Mm-hmm.
cystine stone, if you add it to this guy, the cyanide component is going to convert the, the cysteine, which is the I one, to the E form, which is the amino acid. Do you get that?
But are they not contradicting themselves? Because if it's to test for like homocystinuria, that's like accumulation of homocysteine. There must have been a deficiency somewhere.
No,
Like
no,
we are
no.
not producing
No,
cysteine.
I'm not talking about homocystinuria yet. I'm talking about the cysteine where we use it for initially. Do you get it?
Mm,
So I'm not talking about the homocysteine yet. Homocysteine, you need to add another reagent to it. Do you understand? So
okay.
yeah, so this cyanide is going to convert that cysteine stone to the cysteine, which is the amino acid. So you now combine the amino acid with nitroprusside, you now get a purple discoloration. For homocysteine, it is different. You need to add silver nitrate to that reaction, and if you mix everything together, you are going to get a magenta color. So if you guys want to palm it, it's fine. Just palm it. Nitroprusside cyanide test is for homocysteine as well as for cysteine stone, both of them. That's what you use the nitroprusside cyanide test for. Mm. So me, I just put the homocysteine acid just to help you guys, guide you guys to the answer. So you guys should not
Thank you.
forget that. Yeah, you are welcome. Okay. So because we don't have time, we cannot be analyzing the other options. There's no time. We need to finish. So um a something boy was brought to the office by his parents, who report that the child has been unusually thirsty for the past week. He also has he also has increased urinary frequency and has bed wet, you know, and has wet the bed 3 times in the past 2 weeks. The random blood glucose level is 215 milligram per DL. The pediatrician suspects that the boy has type 1 DM caused by autoimmune disruption of the insulin producing pancreatic beta cells. Which of the following is a transporter of glucose to enter the pancreatic beta cells? So this one is very straightforward. So what transporter?
It's true.
Oh,
But
I
we
think
don't
we,
go.
we did not talk about it.
Not four.
We did not talk about. I'm not sure we talked about it. It's group 4.
So, Dr. Babawale, I thought it's good too because I saw bi-directional. So I felt like it should
Okay.
take it to the spleen, to the pancreas, liver,
Mm-hmm.
and bring it back. That was why I went for 2.
Oh no. That one.
Yeah.
Those ones are not insulin dependent. Those ones are not insulin dependent. Those ones are not insulin dependent.
So insulin dependent is 4,
It's
Happy.
four. It's four. That's the only one that is insulin
Okay.
dependent. And you find it
And that's pancreas and liver alone.
exactly. That is it. That is it.
Okay. So which one
So
is 2?
two, we'll do it when we've done it in GIO. Two is all those kidneys,
What is
liver,
that? Sorry.
intestine. Two is kidney, liver, intestine, and the
Liver.
other place I forgot.
Which one is muscle?
Dr. Toby, two is a
Yes.
bi-directional,
Yes,
Yes.
like
I
two-way
get.
street.
I
Yeah, I now
get,
remember. Yeah,
yes.
yeah.
So
So
my mistake is now thinking is taking it to and from the pancreas. I should have. Do you get?
yeah. The clincher here is just
Uh,
that insulin. Is that insulin. So
Okay.
and
Dr. Baba,
this
with the muscle, which one takes it to and from the muscle?
the muscle. Uh the muscle should be. I think it should be part of one. I can't remember everything completely again, but I think it should be one.
Dr. Babali,
Yeah.
That's a big four.
Hmm? You said?
I thought GLUT4 is muscle and adipose.
The way me too, I'm thinking about it because I'm like, am
Wait,
I
what
the
are
one
we
mixing
saying?
I
things
thought
up?
GLUT4
Wait. The point is insulin. The point is GLUT4 is insulin dependent. So yeah, I think it should be muscle and adipose, like you said. I myself have forgotten them now. But the
Because
point is just that
if pancreas is insulin dependent, that means it won't be able to function when there's, I mean, pancreas is not producing insulin. So if there is something happening to this thing, it won't be able to sense, what's it called, glucose. I feel like ideally the pancreas should be able to sense the glucose and then secrete insulin.
let me
Do
check.
you get?
Let me check. I've forgotten. I've forgotten.
I don't
I
think
don't think
pancreas should be
something.
insulin dependent.
You said?
I was thinking
I
GLUT1
don't
is
think
red
so.
cell,
Dr.
GLUT2 is
Paulette.
I don't
isolate,
think I was thinking
GLUT3 is
GLUT2.
brain, GLUT4
Dr.
is
Man, I
Paulette
don't
Because
think
is
so.
reading it
Okay,
for
okay.
us.
GLUT4
Dr.
is only
Paulette
for
is reading it
adipose and muscle.
for
I don't know
us.
if there's.
Oh yeah.
Dr.
Okay, let's
David, Dr.
listen
Paulette
then.
is reading it for us.
Oh yeah, read it. Thank you, Dr. Paul.
Okay, the way I learnt it was GLUT1 is for red cells, GLUT2 for isolates, that's pancreatic cells.
Okay.
Then
So,
GLUT3 is for brain, GLUT4 is for skeletal and adipocytes, GLUT5 is for small bowels.
okay, thank you. Please, is anybody with
So
FA
group
so that we
five
can just
for
confirm?
Was is it seminal vesicle or something?
Yeah.
Or
I'm,
test it.
I'm
Let me check my
Can
package.
somebody open
I
FA, I
saw know
beg?
that one of those. I'm coming. I'm gonna get you. I get you now.
all those transporters.
I think I'm be so confusing, eh? I
Honestly, in the exam hall, I just remembered bi-directional too.
I'm not even like
I
I'm
can't
even
even
like
remember the page where it
pancreas,
is now.
like
I can't remember the page
It's
where it
in
is.
it's in DM. It's in
page
DM.
yeah, it's the
338.
endo. I'm already in
Page
endo. I'm not
338
even looking for what
endocrine.
page I'm going to open. So
Dr. Francois, can you
338.
please read it? Can you
No,
please
I'm
have
read
you
in
it?
seen
traffic. I
it?
found the page, but I can't read it. If I
What
start to
Oh,
page?
you
move,
have
What
I'll
to
stop.
page?
see it. Okay.
Yeah, I'm in endo, but I don't even know where exactly in endo I'm supposed to check now.
338.
338. Okay. 338. Okay, yes. So insulin, we have the insulin dependent glucose transporter. That's only one. That's GLUT4. GLUT4 is the only insulin dependent transporter, and it's found in the adipose tissue, found in the striated muscle.
Okay.
Exercise can also increase the GLUT4 expression. So GLUT4 is the only one with insulin dependent.
Okay.
Now the insulin independent transporters. Should I go on?
Mm-hmm.
Oh,
So we have GLUT1, which is found in the RBC, the brain, the cornea, and the placenta.
Okay.
Excuse me, sorry. That's GLUT1. GLUT2, bidirectional, like Dr. Toby said. So it's found in the beta, it's independent, it's insulin independent. It's beta islet cells,
Mm-hmm.
liver, kidney, GIT. They're bidirectional.
Okay. That's the only
Yeah.
one I
Then we
remember.
have,
so
yeah,
Bluetooth is correct. Dr. Babale, you
yes.
said I missed it.
Do you know that the funniest is that I actually picked two answers
You
like
said
that? I
I
don't know that
missed
I
it.
removed one.
No, it is that
I was between,
it is that insulin dependency, that I was just focusing on. Yeah. So I forgot where the GLUT4 stuff is, but it makes sense. Yeah. So adipose tissue
okay.
and muscles. You need to take up those muscles, those glucose by the muscles so that they can use them. That's what insulin is trying to do. Yeah, you have to use
Yeah,
them at the
yeah.
end so that you can bring them down by glycolysis.
But Babawale, it speaks to reason if
Please.
the pancreas is not insulin dependent because it doesn't have insulin to drive it first. It needs to sense that glucose,
Mm-hmm.
then produce insulin. So it
Yes,
makes sense for it to be independent of insulin, and
you are
that
very
makes
correct.
sense for it to be both ways. Do you get?
Yes, you are very correct.
So
Very, very
GLUT2
correct.
bidirectional, insulin non-dependent. We are
Mm-hmm.
good. Thanks.
Yeah,
So I got
that's
it.
how.
Oh, I
You
got
got it.
Mm-hmm.
You got it.
it.
You got it. So
Hey,
sorry.
Tata
So sorry.
Toye.
To hair is to human. To hair is to
Okay.
human.
So
So
Babale, no, it's okay.
Dr.
It's not a
Toby,
big
please,
Wait
deal.
can you
now, you people don't want
summarize?
me to say the remaining. So it's because that one came out
Dr.
to your
Toby,
exam.
when
You
you
will not hear
finish,
the
please
remaining, Abby.
summarize.
Dr. Francois, let me just
Please
try and
summarize
summarize
the
my thoughts
question and the
again.
answer for me. The question
Okay,
and
so
the
I'm
the
answer.
sorry,
question
but
is a young boy that presented with signs of diabetic ketoacidosis, and they said there is destruction of the pancreatic cells. So they just wanted to ask that, give that preamble. They now said that which transporters are responsible for glucose transport in the pancreas. So there's glutathione 2, 4, and then facilitated diffusion. So we are looking for the transporter in the pancreas. So from what we read, it is the bidirectional one, insulin non-dependent. So
yeah.
that's good.
So that means that
So,
this answer is wrong. This answer is wrong. So
yes, it's very wrong.
I think they chose group 4. So I'll go and confirm. They chose group 4.
Eh.
Yeah.
Ah. So Ambos can be wrong. Thank you.
No, it's
No,
not
but
boss. This is
I'm
not boss.
sorry. I
that's
have
so
to
small.
say, hello, Doctor Bob. I have to say something. This particular question comes out almost always in U Word when I was doing U Word, and it's always GLUT4 for the insulin dependent glucose transporter. They've never chosen GLUT2, though it's bi-directional.
Yeah. So don't worry, guys. I'm going to check this question again, and so I will know what they are exactly talking about. And then we'll move
Okay, we
on.
can read their tips and explanations, sha.
Yeah.
Thank you, Dr. Precious. No
Okay.
wahala. But I think the learning point
You
for
people
all of
don't
us
need
is
my
that
help
the
again. I'll
pancreas,
close my FA.
I think the thing we just need to learn, take from this is the pancreas is GLUT2
Yeah.
independent. Yes.
Yes.
So regardless of the
Insulin.
question set. Yeah.
Yeah. Is insulin
Thank
independent.
you.
Okay. A 15-year-old boy presents with prolonged fatigue, hematuria, and mild jaundice following a serious infection. He also has it following consumption of fava beans. Blood tests revealed hemoglobin of 10.5 gram per dl and elevated reticulocyte count. A peripheral blood smell shows His bodies. Which of the following best describes the normal action associated with this patient metabolic defect?
I
Mm-hmm.
missed this question, Dr.
So I missed
Babawale.
it.
You know
I
what,
missed it.
guys?
I know the diagnosis.
Na me go put all these fava beans and skinny there. Oh. That question made it. They did not put they did not put all those clinchers. Oh.
But
So
his body is there now.
you said,
Hence body.
yeah,
Hence body. Hence
like
body.
I said I'm the one that added, those that
Ah,
question was very
Fava
wow.
beans,
wicked. It
Sabi.
was very, very wicked.
Interesting.
It was very wicked. So yeah, so Dr. Oluwatobi, why what happened? Is it because you picked in red blood cell only, Abi? I think that's where
Yes.
Exactly,
That's what I picked.
exactly.
you know
Because
Yeah.
I felt it was just red cells.
yeah, like I didn't like, but I'm like, you guys, let's just see what you guys pick at the end. Actually, that enzyme is deficient in the body totally, is all the cells. But why the red blood cells are most susceptible is that they don't have any other way to take care of
Alternative.
oxidative stress
Mm.
aside that.
Okay, okay,
You
okay,
guys know that
okay.
any red blood cells are very limited in their activity. They don't have mitochondrion. They don't have anything.
Mm-hmm.
It,
Small
Yes.
it is
nucleus,
only
small
HMP
organelle.
short. It is only HMP short that those guys are using to survive. You can imagine generating, NADPH from that is it. So they just do glycolysis and HMP short. That is it. That is all. So, it's actually deficient in all cells, but it's a very tricky question. So you guys should not forget that it's deficient in all cells, but red blood cells are more susceptible because they don't have any other way to take care of oxidative stress aside production of NADPH. Some other cells can produce other metabolites that can help them take care of it. So, that's just what I want you guys to pay attention to. Okay. So a 6-year-old boy is diagnosed with a worsening ataxic gait, and a cardiac arrhythmia. His uncle also has this condition, but the symptoms did not appear until he was 12 years of age. What is the molecular mechanism of this disease? So what do we think here? This is our last question.
I went for something about ubiquitin or something like that.
So I picked protein folding.
Yeah, so
I
it's not
actually
protein
picked
folding.
E.
It's not protein
I
folding.
think it's E. It should be
I picked
unstable
E,
repeat,
but I think
resulting
I
in
was
a
wrong.
truncated protein.
No,
Oh,
Dr.
Yeah,
it's
Fabiola,
E.
I think it was wrong.
this is not a frame shift. That would be frame shift. Or maybe like
Isn't the diagnosis Frederick
No,
ataxia?
yes. This is
Uh-huh.
Fredrickson ataxia, exactly. So
Yes.
it's not frame shift, it is trinucleotide repeat. So and those trinucleotide repeat actually suppresses expression of that gene. That is it. Either they suppress gene transcription or translation of the protein. That's what they do. So they don't cause truncation of the protein. This one will be frame shift mutation. Anything that causes frame shift mutation will cause this. So, and frame shift mutation is not the pathophysiology for Fredrickson ataxia. So, causing an amino acid substitution is, maybe a missense, like sickle cell. Splicing is different. Splicing is when we are talking about all those spinal muscular neuron degeneration, spliceosome problems. You guys remember that one, misconnective tissue disease. That's splicing. Then protein folding is things like cystic fibrosis. So that protein cannot fold very well. That is that. So the answer is protein translation. So you cannot say DNA transcription there. So DNA transcription, translation of the protein, like conversion of your mRNA to protein or translation of your DNA to the mRNA. Those are the two things that can be affected in trinucleotide repeat. It will silence that gene. That's what they do. That's what they do. So
Mr. Babali, sorry, I didn't get the answer. So which one? Which one did you say is the answer?
so impede protein translation. So you cannot produce the protein eventually, either due to the fact that there is silencing of the DNA transcription or there is inhibition of the mRNA translation to protein.
Did you say the diagnosis is Frederick ataxia?
Yes, this is Fredrickson
This
ataxia.
is I'm thinking it's Becker's. Okay.
This is what you said. What?
I thought it was Becker's. So let me not lie. So I picked
It
E.
was Becker's. Which one is Becker's?
Becker's. I mean, it's not Becker's.
Okay, Becker's. No. See, okay. But did they have a target gate? They have this problem with standing up. So they have this goer sign. They have to be standing with their body. So like it's that's a very that's one thing with this question. If they put enough clincher there now, like we would have nailed it very well. Just put two things and so but Dr. Precious, once you see this unstable repeat, you know that okay, they are likely talking about one of those trinucleotide repeats. Sure you get. So you
Yes.
will not be thinking about the Bakers again, because those ones are frame shift or nonsense mutation. Frame shift or nonsense mutation.
Okay.
Dr. Babale, you said that when it comes to the trinucleotide repeats, they affect protein translation and what else?
So they can affect DNA transcription, that is conversion of DNA to mRNA. They can silence that gene
Okay.
and not allow the DNA to move to the mRNA, or they can prevent the mRNA from going through the protein, which is translation.
Okay.
So
Okay.
any one of the two.
Okay.
You don't even produce the protein at all. Not that you have truncated protein. You know that truncated protein is different from you not producing protein at all. You don't even produce any protein. That is it. So you guys should also remember that the
So
test.
there's no truncation in Frederick ataxia. I don't know why when I saw truncation, I thought of
No. There's no truncation.
Frederick's
There's no truncation.
frataxin. Okay. All right.
No. So it's the frataxin gene. Yeah, the frataxin protein. That is what is problematic in this guy. So they
Okay.
cannot produce that frataxin protein, and that frataxin protein is an iron sulfur protein that allows for oxidative phosphorylation in the mitochondrium. So it's one of those protein in the mitochondrium that allows for oxidative phosphorylation. So it damages the neurons. The neurons they require a lot of energy, so it damages those neurons. That's why they have so many neurologic problems like ataxia, autism, and all those other things that they experience. Yeah, and as well as the heart too. The heart too requires a lot of energy, so they can have heart issues like um arrhythmias and the other things. Then you guys remember the other things that they have. They have long everted ears. They can have macrochidism, you know, intellectual disability, and all those things.
Frederick takes your macroorchidism in the Fragile X.
Oh, sorry. Sorry, thank you, Doctor. I'm already talking about Fragile X. So, yeah, so Freddy the Texas is more of,
So, Baba, the sciences are heightened now. Exam don't close.
yeah, that's how it should be. That's how it should be, oh. That's how it should be, oh. Which is very good. Yeah. So, they have problem with their heart, majorly, arrhythmias and gait problems, ataxia, So, what else? What else are we adding to that? Freddy's ataxia. They have myopathy, cardiomyopathy. So, what else again? You guys are not adding it.
Diabetes. They have diabetes.
Yes, they can have diabetes. That's very correct. They can have hypertrophic cardiomyopathy. That's the commonest cause of death in them. They can have diabetes.
Yeah.
Yes.
Then they have kyphoscoliosis.
Yes. Hyposcoliosis. Yes. Kyphoscoliosis rather. Kyphoscoliosis. So they have abnormal curvature of their spine. So
yeah,
that is that. All right. So we are going to stop here. At least we've tried. We've